Today we are starting the first online lecture, Control of Pain During Pregnancy. What are the contents? Causes of pain during the first trimester, causes of pain during second trimester, causes of pain during third trimester, true labor pain versus false labor pain, incidental causes of pain, acute appendicitis versus pyelonephritis. Abdominal pain is a very common symptom in pregnant women. It may be due to pregnancy itself, e.g. red degeneration in a fibroid, or may arise from some concomitant lesions such as appendicitis. It is convenient to divide the causes of pain due to pregnancy into those most commonly found in each of the 3 trimesters, though of course there is a considerable overlap. Actually, this is quite common because the trimesters themselves are overlapping. For example, at 22 years old, para 1 with 6 to 8 weeks gestation presents with abdominal pain. What are you thinking of? From the history, colicky pain localized one-sided pain, no radiation, spasmodic to start with, and now constant. Mild bleeding per vaginum, some chest pain and shoulder tip pain, has been feeling unconsciousness. Pregnancy test is always positive. You have to think about ectopic pregnancy. Record vital signs, blood pressure, temperature, and pulse. Beta, human chorionic gonadotrophin quantitative, and urgent pelvic ultrasound is mandatory. Refer or admit to hospital for starting management. Ectopic pregnancy. What are the pitfalls in diagnosis of ectopic pregnancy? Wide variations in clinical presentations, and that's why the diagnosis is a little bit difficult. Pregnancy test can be negative at times of diagnosis. However, it must have been positive at some time or another. Transvaginal ultrasound, even at the best of hands, is only 50% accurate in picking up an ectopic pregnancy. Beta HCGs can double in very early ectopic. Doubling time varies from 1.4 to 7.2 days depending on gestation. Why I'm saying that? Because normally the doubling up to 60% of the original value in normal pregnancy, but concerning the ectopic pregnancy, the duplication is actually less. I mean, maybe reach 30% or 20%. There is elevation of the beta HCG, but not doubled. And that's why the doubling occurs early in gestational age concerning the ectopic pregnancy, and after that, there is a slow increase in the beta HCG. Methotrexate is actually the ideal medical treatment for ectopic pregnancy, with or without the folinic acid. You know, all of us, that the methotrexate dosage is 1 milligram per kilogram body weight, and the antidote folinic acid is 0.1 milligram per kilogram body weight. What about the surgical methods for management of ectopic pregnancy? It is laparotomy or laparoscopy. And through laparotomy or laparoscopy, we can perform whether salpingostomy, or salpingectomy. What's the difference between salpingostomy and salpingotomy? Salpingotomy is to open a linear opening all over the fallopian tube and leaving the after performing the linear suture, we have to remove all the fertilized ovum and then suturing. But salpingostomy, after opening the fallopian tube, to leave behind the stoma, I mean without suturing. This is the only difference between salpingostomy and salpingotomy. So salpingostomy to leave behind the stoma without any suturing, and salpingotomy we have to suture the incision. Follow-up is mandatory, and follow-up for the prognosis of the ectopic pregnancy. What are the causes during the first trimester? Causes of pain during the first trimester is 6, ranging between abortion, pregnancy in rudimentary horn, acute salpingitis, acute retention of urine, identical mole, ectopic pregnancy, abortion, pain preceded by vaginal bleeding, cervix closed in threatened abortion or opened in inevitable abortion by ultrasound, gestational sac is seen inside the uterine cavity, of course, because if seen outside the uterine cavity, it is an ectopic pregnancy. Pregnancy in rudimentary horn. Pain resembles that of ectopic pregnancy and usually the condition discovered during laparotomy. If rupture occurs, it usually in the mid-trimester or the second trimester and of sudden onset with collapse. Acute salpingitis may develop up to the 10th week after conception due to gonococcal infection or infection at attempted abortion. Pain felt in both iliac foci and is continuous. There is associated tenderness, tachycardia, and elevated temperature. Culture of discharge may reveal pathogens. 4. Acute retention of urine. It is usually due to enlargement of a cervical fibroid in response to pregnancy and may occur very early. Severe lower abdominal wall, large tender bladder, which may be mistaken for ovarian cyst. Castration causes immediate relief of pain. Of course, it will resolve the problem immediately. 5. Hydatiform mole. Pain in lower abdomen. Pain may be due to overdistension of the uterus, concealed hemorrhage, perforation, infection, uterine contraction for expulsion. Because this sudden overdistension of the uterus due to the hydatiform mole make the uterine contents or the uterine muscle try to expel the intrauterine contents. For example, a 22 years old para 1 with 6 to 8 weeks amenorrhea presents with abdominal pain. The history changes: lower abdominal colic, heavy bleeding per vaginum, speculum examination, cervix os closed or cervical os opened. The diagnosis is miscarriage. Assess hemodynamic stability, arrange pelvic ultrasound, and management depend on ultrasonographic findings. No role of beta HCG whatsoever, blood group, rhesus, and anti-D if necessary. This is very important. The management of miscarriage: incomplete abortion, inevitable abortion, missed abortion by termination, evacuation of retained products of conception. What are the causes of pain during the second trimester or mid-trimesteric pain? Red degeneration in a fibromyoma, stretching. There are 5 causes. 2. Stretching of round ligament. 3. Acute polyhydramnios. 4. Rupture of rudimentary horn containing pregnancy as in the first trimester. And 5. Acute retention of urine due to incarcerated retroverted flexed gravid uterus as in first trimester. Mid-trimesteric pain. 1. Red degeneration of a fibromyoma causes mild to severe pain. Fibroid tenderness usually presents over the fibroid. Ultrasound usually detects the fibroid during the first trimester. There may be history of amenorrhea before pregnancy. Treatment conservative with analgesics. Here in this case, we have to follow the size of the myomas, follow the symptoms uh, causing, the pain or whatever. 2. Stretching of the round ligament. Actually, 10 to 30% of all pregnancies, there is stretching of the round ligament due to the enlarging uterus. Actually, it is more in multipara, cramp-like or stabbing continuous pain and made worse with movement. Some tenderness in the lower quadrant and groin. There is no constitutional symptoms. Reassurance and sometimes mild analgesia is required. Acute polyhydramnios. Pain is due to overdistension. It can be differentiated from pregnancy by absence of fetal heart sound. What are the causes of pain during the third trimester? They are 5. Concealed hemorrhage, severe preeclampsia, uterine rupture, contractions of labor, red degeneration of fibromyoma as previously described. Concealed hemorrhage. Pain is of acute onset and is severe with considerable shock and collapse. The abdominal mass are tense and the uterus may be larger than expected. Heart tender with difficulty in palpating fetal parts. Fetal heart is usually absent. There may be vaginal bleeding. There may be hypertension before the event. Why before the event? Sometimes when the blood pressure falls, sometimes the patient loses the pregnancy and in this case start of the hemorrhage inside, and this hemorrhage may be revealed or concealed, but in this case the cases where pain is most evident is concealed hemorrhage. 2. Severe preeclampsia. Epigastric pain may occur and is a sign of impending eclampsia. The characteristic signs of preeclampsia, hypertension, proteinuria, and edema are present. The uterus is not tender and fetal parts are palpable and fetal heart rate usually present. Actually, I'd like to say why epigastric pain is so evident, because stretching of the liver capsule, hepatic capsule, that's why due to enlargement of the liver, and that's why epigastric pain may occur. The uterus is not tender and fetal parts are palpable and fetal heart rate usually present. Uterine rupture is a possibility in high-periods women and those who have scarred uterus. Women usually feel a tearing sensation followed by constant pain, shock, and collapse. Vaginal bleeding is a common symptom. Fetal parts easily felt and fetal heart rate is usually absent or distress is seen. Labor pains, prematurely or at term, intermittent and gradually become stronger and more frequent. Cervical dilatation and effacement. Here is a comparison between true and false labor pain. The matter of differentiation is 6 parameters. 6 parameters: contractions, intervals, intensity, discomfort, cervical dilatation with sedation. Contractions. There is a regular interval concerning the true labor pain and irregular intervals concerning false labor pain. What about the intervals are shorter in true but longer in false labor pain? The intensity gradually increasing in true but unchanged in false labor pain. What about discomfort? Discomfort sites in back and abdomen concerning true, and in lower abdomen concerning false labor pain. And what about cervical dilatation? True labor pain is present, but false labor pain is absent, with sedation or sedation administration, it is not relieved by true labor pain. Actually, true labor pain, it is a continuous process. No process can stops it, even tocolytics. But false labor pain, even mild sedation can relieve the situation. An example here, history, 22 years old prime gravida presented with right-sided abdominal pain for about 2 days. She started with a vague pain in the epigastrium and is now constant on the right side. She is now about 26 weeks pregnancy and there is no vaginal bleeding. Her 20th week scan was completely normal. This is a condition of appendicitis, most common cause of acute abdomen in pregnancy. Tenderness over McBurney's point, low grade fever, differential diagnosis, rupture ectopic pregnancy, bilateral serpingio-oophorytes, renal colic, placental abruption, degeneration of uterine myoma. Appendix is progressively displaced upward after 12 weeks and reaches iliac crest at 24 weeks. Single most reliable symptoms in pregnancy is referred pain. Anorexia, vomiting, rebound, gardening are not specific in pregnancy. Leukocytosis is not helpful whatsoever. How to diagnose appendicitis? Graded compression ultrasonography is accurate in the first and second trimester but difficult in the third trimester. Ultrasound is 98% accurate but not so above 34th weeks of gestation. What about the sequelae or consequences? High fetal loss rate if perforation occurs 20%, maternal mortality or maternal mortality of delay. Risk of perforation highest in the third trimester. Premature labor, especially in the first week after surgery. We have also not to forget incidental causes of pain because it's very important and must be kept in mind. There are 11 incidental causes of pain. First one, gastroenteritis. Pain is generalized over the abdomen and accompanied by vomiting and diarrhea and tenesmus. Due to irritant effect of gastric acid on peritoneum, temperature is elevated and abdomen is tender with no rigidity. Stool analysis shows organisms. Here is a comparison between acute appendicitis and acute pyelonephritis. Actually, the site varies with advancing pregnancy and the site remains the same. Colicky pain in acute appendicitis, but in acute pyelonephritis is dull aching pain. What about the acute appendicitis? McBurney's point tenderness is the point of pain, but in acute pyelonephritis, right costovertebral angle tenderness. What about the fever? It is low-grade fever concerning acute appendicitis and high-grade fever. It may reach 42 degrees centigrade concerning acute pyelonephritis. Diagnosis of incidental causes of pain by ultrasound, renal function tests like creatinine and urea, and creatinine clearance, urine analysis. Those are very important in the diagnosis of the causes of pain, especially the incidental ones. 4. Renal and ureteric calculi. Pain may be confused as pyelitis, may radiate to legs and worse on movement. Blood may be present in the urine and ultrasound may show stone in kidney or bladder. Cholecystitis. Right subcostal pain, lower border of the ninth rib, radiating to back and shoulder. May radiate to chest, usually severe and lasts only for minutes or hours. Starts at night and awakes the patient. Ultrasound is very important in the diagnosis of cholecystitis. we can see that there is a second gallbladder wall, and from the thickening, it means that there is a cholecystitis. What about perforation of a hollow organ, such as the stomach or duodenum, may occur with sudden pain, collapse, and the rapid development of generalized peritonitis. Usually history of peptic ulcer or gastric ulcer is present. Chest X-ray reveals gas shadow under the diaphragm. Strangulated hernias should be borne in mind, and hernial sites should be examined. Acute pancreatitis. The onset is sudden with severe upper abdominal pain and vomiting, usually serum amylase and urinary diastase levels elevated. Treatment is usually symptomatic. Acute hepatitis may occur in hyperemesis gravidarum, in severe preeclampsia, or in acute infective hepatitis. In all these conditions, there is pain and tenderness over the right hypochondrium, and jaundice may be evolved. Acute intestinal obstructions, sometimes found in pregnancy, and usually there is history of laparotomy and constipation. The onset is usually sudden, with vomiting, distension, and colicky pains are typical. Lastly, torsion of ovarian cyst may occur, especially during first trimester. Pain is at first referred to one or other hypochondrium. So the pain is referred to one or other hypochondrium and is acute in onset, usually with vomiting. As peritonitis occurs, there is pain, tenderness, and rigidity over the tumor. There may be some pyrexia. Transvaginal sonography reveals the cysts. Doppler is very mandatory to differentiate between the multi-septed ovarian cyst, and in this case there is maybe an issue of malignancy or pre-malignant lesion, and that's why the Doppler is very important, because in Doppler we have to perform the pulsatility and resistant indices. At the end, we can ask some question to cover this lecture. What are the causes of pain during first trimester? What are the causes of pain during second trimester? What are causes of pain during third trimester? Give differential diagnosis between true and false labor pain. What are incidental causes of pain? Differential diagnosis between acute appendicitis and pyelonephritis. Thank you very much for your attendance.